and attending our Caregiver Conference. We're very excited to be here and to offer you today a fabulous lineup of speakers on various topics and resources available in the community. I am Lynn Miner with the Utah Department of Health, and I am the Alzheimer's and Related Dementias Director. And I have been in this position for about 2 years, and previously had worked in communicable diseases for 25 years at the State Health Department. So how many people here know that we actually have a state plan for Utah on Alzheimer's and related dementias? How many? A few, okay. In 2012, the Utah State Legislature actually developed a state plan recognizing that this is a public health issue and that we needed to have goals and objectives that were written specifically for the state of Utah. And we have a wonderful plan that was developed with 5 goals and many recommendations and strategies. And my goal is to implement all of the goals and recommendations that have been outlined in our state plan. We have quite a few people here today that are on our coordinating council. The coordinating council is made up of representatives from across the state who are interested in this area and actually working to do something about it. So if anyone is interested in the Alzheimer's and Related Dementias Coordinating Council, please talk to me, or also Ronnie Daniel is the co-chair sometime today. We'd be happy to give you more information about the council and when we meet. So today's agenda, and we have a small sheet of paper here. I just wanted to go over it briefly with you. We are going to have an overview of dementia and what's happening with current research on a national basis. After that, Dr. Kathleen O'Bray and Helly Brand will be talking about what to do after a diagnosis. What happens, the next steps, who should you see? Following that, we are going to have a presentation by Luann Lundquist on understanding dementia behaviors. What are the common behaviors associated with dementia, such as wandering, repeating themselves, and what to do about it. Then we'll have a presentation by Kate and Anita on safety concerns for dementia patients. So safety issues, what to do if wandering occurs, and some resources to help you, such as the medic alert. And then Carrie Scanlaw from the 5-County Area Agency on Aging is going to talk about community resources and what's actually available here in the 5-county area. And then we will have an opportunity at the end for questions and answers for all of us. So we'll have a panel, and feel free to bring up all of your questions and concerns at that time, because we'd also like to hear what other resources are needed in this area and how can we help you. So without further ado, I'm going to turn the time over to Kate Niederostic. And Kate is the program director for the Alzheimer's Association with the Utah chapter. And immediately following Kate is going to be Ronnie Daniel, who will talk about research nationally. And Ronnie is the executive director of the Alzheimer's Association. So I'll turn the time over to Kate.
Okay, well, welcome. So today we're just going to start off with a basic overview of the difference between normal aging from a cognitive standpoint, dementia, and Alzheimer's disease, so that we're all kind of on the same page here. Hopefully this will assist with everything else that we're discussing, kind of lay the groundwork. So when we talk about normal aging, as you may know, our bodies change quite a bit as we get a little bit older. Same with our brains. Our brains change as well. This is a list of typical changes we can all expect to occur from a cognitive standpoint, okay? So making a bad decision once in a while, some of us are very good at that. Occasional errors when balancing our checkbook, confused about what day it is and figuring it out later. Turn the volume? Yeah. Okay, we're gonna check the volume. Thank you. So especially if you're retired, you're not following a specific schedule anymore, it can be easy to get your Mondays and Tuesdays and whatnot confused. But then you're able to figure that out and get back on track. Sometimes having trouble finding the right word. I know for me, especially if I don't have a good night's sleep, a couple nights in a row, I have difficulty putting my phrases together. Hopefully that doesn't happen today. And then misplacing things from time to time, but we're able to retrace our steps and find those items. Also, what I would consider the what did I come in this room for scenario that happens all the time, it seems, right? So this is our list of normal challenges that we should all expect as we age. Very different from dementia, which we're going to talk about in a minute. When we talk about Alzheimer's disease, most people think about memory challenges. And so let's talk about normally what happens with our memories. So in our temporal lobe is our hippocampus, which is known as our memory center. And I like to refer to it as a filing cabinet. So all of the information, all of the data, anything we've learned over the course of our life is stored in this filing cabinet. Some of us are a little younger, we have a smaller filing cabinet. Some of us have a larger filing cabinet system that could maybe take up the room. So depending on the size of your filing cabinet, that's going to determine how much time you need to recall information. If you want to recall a memory, just open up one of those drawers, sift through those files, pull out a file folder, and you've recalled that memory. It's typically how it would work. For someone who is 90, it's going to take them longer than someone who's 60 to recall specific pieces of information because they have 30 more years worth of data to sort through, okay? So recall is another challenge or something that takes a little bit longer as we get older, but very normal. And then in a few slides, we're going to talk about what happens when forms of dementia affect that hippocampal filing cabinet. So let's look at some PET scans. So this is a PET scan of a 20-year-old. And what we're looking for in PET scans is we're looking for activity in the brain. Okay? So these are neurons that are firing, that are showing a lot of activity. And so the red, orange, yellow areas of the brain are the highest activity areas. Okay? This is what we should be seeing for a 20-year-old. This is a PET scan of an 80-year-old. Do we see much of a difference?
How about a 100-year-old?
Oh, a 100-year-old. I do not have a PET scan of a 100-year-old here. Right? There's always somebody. I don't have one, but hopefully it will look very similar to this one.
97.
97? All right. So right here is about where we see the difference. This is actually our hippocampal area, that filing cabinet area. So it will explain why recall takes a little bit longer as we get older. But other than that, not much difference, right? So in a bit, we're going to look at the PET scan of someone with Alzheimer's disease. I don't have that 100-year-old, but I'll work on that for the next time. Okay, so now let's talk about mild cognitive impairment, otherwise known as MCI. This is a diagnosis that's fairly new. It's been around the last 15 or 20 years, has gained some momentum. This is when physicians are working with individuals where they're noticing they're having some cognitive challenges, some cognitive deficits, but they're not severe enough to be considered a form of dementia. So if you've heard of MCI, this is what the physician's talking about. So this is a very subtle memory disorder, but it is measurable, meaning that it's showing up on cognitive screens when you go for your annual wellness visit. Who's doing their annual wellness visit at their physician's office? A few people. So do you know that Medicare covers a visit with your physician? It's a preventative measure type of a visit. It's a free visit when you have Medicare. It's called their Medicare annual wellness visit, so it's free. It's a great way. It's not your typical visit, come in when you only have concerns, but it's more of a preventative measure. So the layout of that exam looks a little bit different, but what should be part of that annual wellness visit is basic cognitive screening. Okay, so for those that are doing their annual wellness visit, who's having cognitive screening as a part of it? Fewer hands. Okay, so let's ask our physician to include that basic cognitive screening during your annual wellness visit. And we will hear from a physician and a PA a little bit later, so that's a great time to kind of ask those questions. So MCI, or those challenges associated with MCI, can come out during those basic cognitive screens that you're doing with your physician. The symptoms, as I mentioned, aren't severe enough to be considered a form of dementia, meaning they're not impacting your ability to function on a day-to-day basis that much. But other individuals notice it. It's coming up on screens. Friends and family, yourself, notice it as well. Individuals with MCI do have an increased risk of then developing into Alzheimer's disease or another form of dementia. Okay? So just something to be aware of. Next, let's talk about dementia. So dementia is this kind of broad overall term, often referred to as an umbrella term, because people often ask, what's the difference between Alzheimer's and dementia? Dementia isn't a diagnosis in and of itself. It's considered kind of a syndrome, or this descriptive term that's describing, explaining why dementia symptoms are occurring. Okay? When we talk about, so let's equate it to a cold. If you have a cold, the different symptoms you might have: stuffy nose, fever, chills, aches, those kinds of things. We see symptoms with dementia as well. So these are some of the symptoms that we'll see. Challenges with memory. You don't always have memory challenges with every form of dementia, but it does accompany a good majority of them. Communication and language difficulties. Difficulty with reasoning, not being able to reason through a situation. Poor or decreased judgment. Changes with mood or personality. Problem-solving challenges, those executive function type skills. Increase in confusion. Difficulty with learning new things. Visual perception, challenges with understanding what your eyes are seeing. And then challenges with planning and more and more. So these are an example of the different types of symptoms that we're describing, or we're oh, go ahead.
My dear wife, she died with Alzheimer's. Well, I seen it from the time she started, lived right with her, fed her every day, took care of her. The thing at first started to show is her eating. She got to where she wouldn't eat it. She wouldn't fix anything. It got to be a real problem, so I caretaker. I know a lot about it.
Okay, did everyone hear that? So he lost his wife to Alzheimer's disease, and you saw a lot of these symptoms with her. And one was difficulty fixing meals. So that follows the planning process, absolutely, to be able to follow a recipe or go through the steps of making a meal, absolutely. So you've seen it firsthand. It's very tough, absolutely. I'm glad you came today, thank you so much. So these are the different symptoms that we can expect to see with various forms of dementia. Now, there are different reasons why we're seeing those symptoms. Some reversible conditions will actually cause dementia symptoms. So let's go through those. An infection is one example. Upper respiratory infection, urinary tract infections, those kinds of things can certainly throw you for a loop. Medication changes, or medications that are interacting poorly with the other medications that you're taking. Vitamin deficiencies. Thyroid abnormalities. Dehydration is another one. Constipation. Grief. Alcohol use. Poor diet. Sleep problems, and more and more and more. So these can sneak up on you. They tend to happen, these changes tend to happen either over a long period of time or can be very quick depending on what's going on. So I can tell you an infection situation can happen very quickly if you're noticing a drastic change with that individual from one day to the next, a drastic change in their cognitive ability. It's probably because of some kind of infection. There might be a medication change. I worked with a gentleman in the assisted living community that I ran in Maryland, and normally very alert and oriented. He would get around the community in his electric scooter on his own. And then one evening, we found him out in the parking lot, dragging his electric scooter behind him, carrying a lamp from his room, and wearing nothing but his underwear. And so I knew something was wrong. Something's different with Charles, I said. So Charles had actually been visited by the physician earlier that day, and they made a slight adjustment to his medication, but it caused that type of condition. So, thyroid problems as well. If you're deficient in certain vitamins or certain, if your thyroid isn't working properly, that can certainly throw things for a loop. So we want to check these challenges first when we're noticing any of those dementia symptoms. We're hoping that it's one of these conditions, because if it is, we can treat that and we can reverse those symptoms. So now let's talk about irreversible causes of these dementia symptoms, or symptoms that are coming from a neurodegenerative, for a neurodegenerative reason. First and foremost, we have Alzheimer's disease. It's the most common form of dementia. It makes up 60 to 80% of all dementia cases. Creutzfeldt-Jakob disease, if that sounds familiar. Former speaker Becky Lockhart passed away from that a few years ago. It's a very rapid progressing prion disease in the brain. Dementia with Lewy bodies, I'm going to talk about that one in a second. Well, I will tell you, dementia with Lewy bodies, if that sounds familiar, that's what was determined was Robin Williams' diagnosis. And FTD, or frontotemporal dementia. FTD is where you'll have primarily damage in your frontal lobe or your temporal lobe. And there are different types of FTD. There's a behavior variant version where individuals will overreact to situations, become upset, can become aggressive. They tend to not follow social norms as far as behaviors. And then you have a language variant form of FTD, where individuals will have difficulty processing language or speaking, understanding what others are saying or speaking. Huntington's disease, yeah?
That frontal one that you were talking about, is that only genetic? Because I think my dad has a stroke-related frontal. So is there two types of frontal lobe, or is it?
So the question is, are there multiple types of frontal temporal dementia? There are.
Genetic over here, but I know he has stroke-related.
Okay, so if he had stroke-related, it's probably vascular dementia, which is one we're going to get to in a minute. But FTD, there are multiple forms of FTD, and that's a good point. We do have one of our vendors here is the I just blanked on their name, Association for Frontotemporal Degeneration. So there's information there for sure. But there are multiple forms of FTD. FTD tends to occur in individuals that are a little bit younger. So, but if it's stroke-related, it might be vascular dementia for him, which can occur. You can have damage in the frontal lobe, and then you'll see similar symptoms. So
it's not the same thing?
Not quite. It's in some dementias you'll see similar symptoms. It's just fine-tuned determining exactly the cause of those symptoms. And in many cases, you can have more than one type of dementia. A lot of times, individuals with Alzheimer's disease will have vascular dementia as well, or dementia with Lewy bodies. So you see more than one type of dementia more often than not. Yeah, which makes it difficult for the diagnostic process. Yeah. So Huntington's disease is a very rare, very genetic form of dementia, usually occurring in younger individuals, as well as FTD. Korsakoff syndrome is a deficiency in thymine, most oftenly associated with excessive alcohol use over time. Normal pressure hydrocephalus is a buildup of fluid in the brain, which is then causing damage. We have Parkinson's disease dementia, and so I wanted to wait to come to this one with the tag again with dementia with Lewy bodies. Dementia with Lewy bodies and Parkinson's disease dementia are actually sister diseases, sister syndromes. So depending on where the damage is in the brain, and depending on the onset of symptoms, that determines what disease you have. If the individual has the Parkinsonian movement first and then dementia symptoms later, then that's Parkinson's disease dementia. If they have the dementia symptoms first and Parkinsonian symptoms later, that's dementia with Lewy bodies. But they look very similar in the brain. It's just a matter of where that damage is. Then we have traumatic brain injury. So most often that's occurred for seniors, that occurs because of a fall, car accidents, concussions, those types of things. And then vascular dementia. And so that's where you have a stroke or an infarct that's leading to a reduction in blood flow in the brain, okay, which then causes damage, and more and more and more. So the most common form of dementia is Alzheimer's disease. Your second most common is vascular dementia. Third is dementia with Lewy bodies, and then FTD. So let's get into what exactly is dementia. So again, it's kind of that umbrella term, but with dementia, we're in order to actually be diagnosed with a form of dementia, we're needing severe impairment in at least two of these core mental functions. So with Alzheimer's disease, it's memory. That's the first challenge we see. We'll deal with communication and language as well. With posterior cortical atrophy, which is another type of dementia that wasn't on the slide, visual perception is the main issue you deal with there first, or the first issue you deal with, because that's affecting your occipital lobe in the back of your brain. So let's look at the different lobes of the brain. So here's that occipital lobe. So posterior cortical atrophy kind of starts in this area. This is your temporal lobe, the green section. That's where that filing cabinet is stored, your memory center. That's where Alzheimer's disease starts. So that's why memory is the first challenge. You have your frontal lobe here, this blue part. That's responsible for executive functioning, thinking, planning, your emotional center. So that behavior variant form of FTD, that's in this area. And that's why individuals will overreact to situations. Or the language portion of FTD is in this area. This is your parietal lobe, which is making sense of the world, math, spelling, perception, those kinds of things. So depending on where the damage is in the brain, you'll see different symptoms. If it's vascular dementia or if it's traumatic brain injury, the damage could be anywhere, and you could see a number of symptoms. Eventually, dementias will affect this area of the brain. Your brainstem, which is responsible for breathing, heart rate, alertness, and consciousness, and then your cerebellum, which is balance and coordination. So this is why these progressive forms of dementia are also fatal diseases. So let's look at a video we're specifically going to talk about Alzheimer's disease now. Let's look at a video that kind of explains how Alzheimer's progresses through the brain.
What is Alzheimer's disease? Alzheimer's is a slow, fatal disease of the brain affecting 1 in 10 people over the age of 65. No one is immune. The disease comes on gradually as two abnormal protein fragments called plaques and tangles accumulate in the brain and kill brain cells. They start here in the hippocampus, the part of the brain where memories are first formed. Over many years' time, the plaques and tangles slowly destroy the hippocampus, and it becomes harder and harder to form new memories. Simple recollections from a few hours or days ago that the rest of us might take for granted are just not there. After that, more plaques and tangles spread into different regions of the brain, killing cells and compromising function wherever they go. This spreading around is what causes the different stages of Alzheimer's. From the hippocampus, the disease spreads here to the region of the brain where language is processed. When that happens, it gets tougher and tougher to find the right word. Next, the disease creeps toward the front of the brain, where logical thought takes place. Very gradually, a person begins to lose the ability to solve problems, grasp concepts, and make plans. Next, the plaques and tangles invade the part of the brain where emotions are regulated. When this happens, the patient gradually loses control over moods and feelings. After that, the disease moves to where the brain makes sense of things it sees, hears, and smells. In this stage, Alzheimer's wreaks havoc on a person's senses and can spark hallucinations. Eventually, the plaques and tangles erase a person's oldest and most precious memories, which are stored here in the back of the brain. Near the end, the disease compromises a person's balance and coordination. And in the very last stage, it destroys the part of the brain that regulates breathing and the heart. The progression from mild forgetting to death is slow and steady, and takes place over an average of 8 to 10 years. It is relentless and, for now, incurable. Helping your family, friends, and neighbors to better understand Alzheimer's will reduce stigma, improve care, and even help the fight for a cure. Thanks for helping to do your part. Learn more at www.aboutalz.org.
Okay. So remember those different symptoms. Did I turn it back up? Okay. Is that better? Okay. So remember those different symptoms, because that's going to come into play later when we talk about the challenges, the behavioral challenges, the safety challenges that individuals with dementia are experiencing and how we can adjust for that. So let's talk about Alzheimer's disease. As I mentioned, it's the most common form of dementia, making up anywhere from 60 to 80% of all cases. It's not a normal part of aging. It's not something we should all expect. But of course, as we get older, our risk factor increases. It is, as the video mentioned, it is progressive, and it is degenerative, and it is fatal as well. Currently, there's no way to prevent, slow, or cure the disease process, but Ronnie's going to talk about a little bit about research and why research is so important to ending this disease process. So let's go back to that filing cabinet analogy. So remember, our hippocampal filing cabinet in our brain, our memory center. We want to recall a memory, we open up the drawer, sift through those files, pull out that file folder, and we've recalled a memory. What happens with Alzheimer's disease and other forms of dementia that attack that temporal lobe is it's almost like the bottom of that filing cabinet drawer starts to disintegrate. And those files that are stored there are slowly dropping through, falling through. They're not stored there anymore. This happens with your most recent, most current memories and then works its way backwards in time. So short-term memories are affected first. Eventually, all long-term memories will be affected. But it takes some time to get there. So it explains why memories from 10 years ago we're not able to access. But 50, 60 years ago, they're still safe and secure. We can talk about those memories. We can pull those up. It will also explain why we have those repetitive conversations over and over again with individuals with dementia. I just answered that question. Well, I don't have the memory of us having that discussion because when I was trying to store that memory in my filing cabinet, it didn't store. There was no place for it to sit there secure. So that memory is gone. So no, we didn't have that conversation already. So that's what tends to happen as far as the memory with Alzheimer's disease and other forms of dementia that attack that filing cabinet. We're going to look at a few brain pictures. These are drawings of brains just to kind of show what's happening specifically through Alzheimer's disease. We're going to talk more about Alzheimer's than anything else today. But these are pictures of individuals with older drawings of Alzheimer's brain. So this is preclinical prior to a diagnosis of Alzheimer's disease. So just notice the overall, the overall size of the brain, how large it looks and how filled out. This area and this area is your hippocampal filing cabinet there. This is mild Alzheimer's disease. So already we're noticing that hippocampus area to be a little diminished. The cerebral cortex is starting to become a little bit more cavernous, and overall the brain is shrinking due to challenges in activity with neurons. And then this is severe Alzheimer's disease. Now let's look back to those PET scans. So here's a PET scan again of a typical 80-year-old individual. Again, the red, orange, yellow colors are what we want to see with this specific type of scan. Those are the high active areas of the brain. Your neurons are firing and sending messages and communicating with the rest of your brain and your body. This is the PET scan of an individual with Alzheimer's disease. So quite a bit of difference. So when we talk about challenges going forward, we talk about behaviors, we talk about safety concerns, we talk about things that right after a diagnosis, considerations that need to be made. This is why individuals are having challenges making decisions on their own. They have challenges maintaining safety for themselves, and they need more and more assistance. This is also why we have the great vendors around the room here that offer resources and support for you, the family caregivers, because it's difficult to do this alone, okay? So with that, I'm gonna bring Ronnie up to talk about the latest in kind of what's going on with research.
Thanks, Kate. She's awesome. So definitely during the break, take some time to talk to her. She can give you some great information. So as Kate mentioned, I want to talk really briefly about some of the research that's happening, because you all are dealing with Alzheimer's or related dementia, and we want to find a way to cure this. And that's the challenge. And so the first thing I want to just mention is that the Alzheimer's Association, along with thousands of other partners throughout the world, are working on this. This slide just shows a lot of the different types of efforts that are being made to try to find a way to prevent this disease, cure this disease, or at least slow it down. Right in the middle where it says AAIC 17, every year the Alzheimer's Association convenes an international conference and bring together over 5,000 researchers from around the world to look at all the different things they're working on, to compare notes, to collaborate and coordinate the research efforts that's going on around the world. And so the Alzheimer's Association certainly is a catalyst to help find a cure for Alzheimer's disease. And we like to say we're the global leaders in Alzheimer's research because of the efforts of bringing everyone together. And so as we look at, Kate talked a little bit about this, the continuum of Alzheimer's disease, from normal cognitive function through the end of the disease. And so there are really three different major areas that research is happening. So the first area is that's going on a lot recently is in how can we help people who currently have this disease? And so many of you are probably familiar with a couple of drug remedies, Dementia or Aricept. Those are two very commonly prescribed drugs that help with that cognitive function. And so that's where the research has been in the last little while. But we're also now noticing that a lot more research is happening in with MCI, the mild cognitive impairment, and more research is happening in this preclinical area, so that we can find ways of, if you have a predisposition for this disease, wouldn't it be great if we could find a cure before you start seeing any symptoms? A few weeks ago, we had a symposium up in Provo, where one of our researchers at Brigham Young University, Dr. Keone Calloway, talked about the genetic component to this disease, and the ability that we're starting to now see through a genetic test to find 10, 20, 30 years before you might see symptoms of Alzheimer's disease to know if you have a predisposition for that. So as we begin to start to find ways to prevent, that's where the benefit is coming in. And so we're not there yet, but the researchers are seeing some really incredible things here. The other areas of research that are very fascinating are looking for biomarkers of this disease. They haven't found any specifically yet, but these biomarkers are things that you're already familiar with. Kate mentioned your annual wellness visit. When you go there, your doctor almost always checks your hemoglobin, your insulin resistance to see if you have diabetes. And that's a biomarker that can determine whether you might eventually get diabetes. Another one is you do a blood test to check your cholesterol to see whether you are in risk of having a heart disease. So they're looking for those type of biomarkers that through a blood test or some other means could determine whether you might have the predisposition for Alzheimer's disease or related dementia. Kate mentioned the PET scan imaging that's going on. This is a relatively recent research method that they're using to better diagnose the disease and look at different parts of the brain that are being affected. The video that we watched talked about two predominant theories of what's causing Alzheimer's disease. The first is a buildup of beta amyloid plaque, which is a protein that destroys neurotransmissions in the brain. The other is the tangles, which is called the tau, and the interaction between your neurons in that synapse. The tau creates tangles that disrupt that synapse, and so those are the two believed to be primary causes of this disease. And so a lot of research is happening now to determine how can we stop the buildup of that beta amyloid plaque in the brain, or if it's already there, how can it be diminished? And so there are about a half a dozen pharmaceutical treatments that are in phase 3 trials right now, looking at how to break up and destroy the buildup of that plaque. And so it's pretty fascinating. Again, we're not quite there yet to have this available to everyone, but the fact that they're in phase 3 trials means that within 5 years or so, if these drug trials are successful, that there very well could be a pharmaceutical solution to destroy or break down that beta amyloid plaque. So as I mentioned, right now the current treatments that we have are based in this area over here, in the trying to help fight the symptoms of this disease. And it doesn't cure the disease, but it does help combat the symptoms. But there's also looking at this preclinical, trying to find ways that we can delay the onset of the disease, find the evidence of the pathology, help decrease the accumulated beta amyloid plaque, and decrease the neurodegeneration from this tau tangles that are built up. And then the research is really moving from this area to this area, where we can start to find ways to reduce the risk for people altogether and delay the onset of Alzheimer's disease pathology, stop the buildup of this beta amyloid plaque and the prevention of the tangle development altogether. So that's where the research is headed right now. The other incredible research that's happening is what can we do? Do we know anything about our ability to prevent this disease? And so on the bottom of this slide, we know that there are things that we can do to decrease our risk for getting Alzheimer's or related dementia. The more years of formal education is one thing that we can do to reduce our risk. And that doesn't mean you have to have had a formal college degree, but that's learning new things on a regular basis. So keeping your brain stimulated, learning new things, and that can start at any age. It doesn't have to start when you're in your 20s going to college. It can start today. Coming to classes like this to learn new things, stretch your brain is very beneficial. Physical activity. Being regularly active and physical is a way that you can reduce your risk. And that doesn't mean you have to go become a bodybuilder, but really taking a 20 to 30 minute walk every day is a great place to start. Eating a heart-healthy diet. Most often it's the Mediterranean diet that's recommended, which is low fat, eating a lot of fruits and vegetables, doing things like that can help reduce your risk. And then they also know that moderate alcohol consumption or eliminating alcohol consumption and social engagement can also be a great way to reduce your risk. But on the converse side of that, we know that there are things that will increase your risk for getting cognitive decline. So Kate mentioned traumatic brain injury is one. So reducing your risk of falling and having brain injury is a great way to do that. Midlife obesity and midlife hypertension, so not taking care of your heart, are great ways to increase your risk. Smoking, diabetes, depression and history of depression are other ways that can increase your risk. Sleep disturbances, this is another one that's just come out at the last Alzheimer's International Conference, was that if you're not currently getting at least 6 to 8 hours of sleep on a consistent basis, your risk for having this disease increases significantly. And then hyperlipidemia is another increased risk. And so these are things that we know now. In fact, the Alzheimer's Association is launching a nationwide study in 2018 called the Pointer Study. And it's going to be on a state-by-state basis, trying to track people in what they eat, how much sleep they get, the exercise level they have, to see over a 5 to 10 year period if we can see some impact on there. I have a question.
I just wanted to know what that one last thing you said. You said it was
Hyperlipidemia, and I'm going to go to some of our experts here. I'm not sure the best way to explain that. You need to, what is hyperlipidemia?
It's really hyperlipidemia.
Okay, there we go, hyperlipidemia.
It's kind of associated, in a very simple way, it's kind of associated with cholesterol. It's too much fat in your blood.
Great, so too much fat in your blood. So eating that low fat, again, go back to that low fat diet, is a great way to reduce that. So with that, we have just about 2 minutes for questions, so I'm happy to answer any other questions, and whether that's for myself or for Kate, we can respond to any questions, and we'll go to the next speaker. Yes?
Can FTD progress to Alzheimer's, or is that
Yeah, so each of those forms of dementia that Kate talked about are progressive in nature. So just like that video showed the progression of Alzheimer's disease, they all eventually will progress through the same thing, and it begins to destroy different parts of the brain. Really, the main difference between all those different types of dementia are the place where they first are shown. So if the first symptoms that you start to see are memory related, then that's more Alzheimer's disease. If the first symptoms you might see are behavior, that might be more frontal temporal related dementia. And so it's a little bit challenging, as Kate mentioned, that a lot of these types of dementia are intermixed in a lot of cases. In fact, I was speaking with one of the researchers, Dr. Kevin Duff, at our conference a few weeks ago. And he was saying more and more the diagnosis is coming back, not specifically Alzheimer's disease, but it might be Alzheimer's with AFT or AFT with Alzheimer's. And so there's a lot of intermixing between those diseases. And a lot of it is when do you get the diagnosis? Are you getting diagnosed early on when you have just a few symptoms, or later on when you have multiple symptoms? And so that's why it's a little bit confusing. Good question. Any others? Yes?
When do you get diagnosed? I mean, for all those things, who do you see? Do you see a neurologist? Do you see your internist?
So the question is how do you get diagnosed? Who should you see first? I'm going to let Kate answer that.
You should start with your primary care, your internist or your geriatrician as your primary care physician. You should start there with that basic cognitive screening that we mentioned, and then that physician will make a referral for additional screening. Usually psychologist or neuropsych is involved, neurology as well. There's a whole process to the diagnosis, and in the back at the Alzheimer's Association table we have a basics of Alzheimer's disease brochure that will talk about the diagnostic process as well as stages, and there's also a flyer that takes you specifically through the different tests to expect as someone's going through that diagnostic process. But it absolutely starts with your primary care physician.
And I wanted to mention one other thing that I forgot related to all the research. There is a great opportunity for all of us to be involved in the research. We can register for different trials that are going on, and they don't all include medication. There's trials that there are research going on for caregivers, and so we have some information at the back table as well for you to get. It's called Trial Match. You can go online, you can register for this, and it will make you aware of all the different research programs that are happening close to you, and then you can find one that you want to participate in and be involved with. But that's the only way we're going to find these solutions, is by folks like us being involved in the various trials that happen. So looks like we're out of time. So